Okay, great. So lateral sprains is the most common lower extremity injury. It's the most common injury we see in emergency rooms across this country. 30,000 per day just in this country alone. It's a very common athletic injury, especially in more high-impact sports. In terms of the anatomy, the primary static stabilizer of the ankle are the ligaments. So the ligament complex, the ATFL is the primary strain to inversion and plantar flexion. It lies within the capsular layer of the ankle. The calcaneofibular ligament, primary strain to inversion and neutral and dorsiflexion. That's in line with the retinaculum. And the posterior talofibular ligament is the strongest one, usually not disrupted when we're talking about these injuries. So rarely is an MRI indicated in the acute setting. Sometimes the elite athletes get them to rule out other injuries and also to help guide them in terms of their time out from sports and the timing when they can start the rehab. It can also help sometimes with commonly missed diagnoses that you might miss on x-ray, such as a syndesmosis injury, peroneal tendon injuries, Achilles tendon injuries. You also want to evaluate the alignment to see if that's contributing to the instability. You want to rule out any commonly missed fractures, so any osteochondral lesions, which we'll be talking about later today, lateral process fractures of the talus, anterior process fractures calcaneus, fifth metatarsal fractures, and list rank injuries as well. So the treatment for the most part is successful with physical therapy program, proprioceptive training, bracing, protection, icing, anti-inflammatories, and the majority of patients will heal up. So acute surgical repair is not supported in the literature. It's usually good to try at least 3 to 6 months of non-surgical treatment. Unfortunately, though, still 20 to 40% of the time, patients can have persistent pain and instability. One study even showed 40% of patients sometimes can still be symptomatic 6.5 years later. And this is what we're worried about, is that if you have developed chronic instability, your ankles will be deficient laterally or medially. You can develop persistent recurrent injuries, buckling, giving way, that can lead to persistent pain and also potentially arthritic changes. So eventually, if you fail non-operative treatment, there's surgeries indicated, and a variety of these repairs have been discussed in the literature. The semi-anatomic and non-anatomic repairs, which are listed here, have kind of fallen out of favor over the years. They had higher complication rates. You had to sacrifice normal anatomic structures, and over time, their results tended to deteriorate. So for chronic ankle instability now, really anatomic repair reconstruction is the standard of care. You want to try and more closely restore the normal anatomy and mechanics. Technically, these procedures are relatively simple. You try and maintain full range of motion, and the results have been pretty good, excellent good results, 85 to 95% across the literature with the modified Brostrom, as long as the patients have high quality local tissues that you can affect and repair, and also well-aligned hindfoot. So some other considerations in your patients that you want to be aware of to make sure that it doesn't compromise your outcome. So if patients are ligamentously lax, if they have hindfoot malalignment, if they're heavy, if they're a high demand athlete, if they have an ossicle, as you can see here, which can leave a void and make the repair a little bit more difficult, if it's a revision case, or if the patients have persistent subtalar instability or arthritis. So the gold standard, again, is the modified Brostrom, was described back in 1960s, where you repair the ATFL and possibly the CFL. You reinforce it with a band of the inferior extensor retinaculum. It allows you to achieve full ankle range of motion. You preserve subtalar joint. You don't disrupt the tendons. And the way I do this, so I do with regional anesthesia. You place the patient supine. You put buttocks you can put under the knee and the ankle, but you want to make sure that distal pad is proximal to the ankle joint, so you don't have a pseudo-anterior drawer position during the repair. Most studies have shown that arthroscopic exam at the same time can be beneficial. You can see associated problems, synovitis, loose bodies, osteophytes, potential osteochondral lesions. Only 20% of these can be seen at the open procedure. There have been a lot of studies now that have shown significant pathology that will be evaluated at the time of arthroscopy. And so I routinely do an ankle arthroscopy quickly before I open for my procedure. Again, there's supine. I typically use a 3-5 or a 4 arthroscope. Use my standard portals, anterior, medial, anterolateral, and then you treat the intra-articular pathology first. Before stabilization, you can also confirm the ankle, the instability laterally, medially. You can make sure there's no syndesmosis instability with the arthroscopy, and we'll be looking at that in the lab later as well. And pretty much depending, I typically don't have to use distraction, but if I have any kind of osteochondral injury, then I'll use a non-invasive distractor. And then once I've done with the arthroscopy part of the procedure, then I'll close the portals, and I'll actually just do a re-prep with a ChloroPrep, and I'll change my gloves. Again, then we proceed to the modified Brostrom. The skin approach, you can either do an anterior J incision or extend side oblique incision over distal fibula. You want to do a full thickness flap down to the capsule. You mobilize the retinaculum so you can see where it is for the later repair. You can examine the perineal tendons this time, just make a small little slit in the sheath and see if there's any damage. You can repair it at that time. You also want to evaluate the CFL. So most of the time the ATFL is injured. Sometimes the CFL, they do share a common fibular insertion, so you can examine that at the time. 80% of these patients can have subtalar instability, so you want to evaluate at this time. Then I usually divide the capsule and ligaments off of the distal fibula, leave a 2 or 3 millimeter cuff for repair. You can see it's very stretched out. It's usually thin and attenuated. And then I elevate that up subperiosteally, and I roughen up the distal fibula to help with the repair. I then advance. I use anchors. Historically, you could use drill holes. Most people use anchors today. So I put the 2 anchors in the distal fibula, and then I actually use 3 passes of the suture. So I pass it through the ligaments and then back through the periosteal flap, almost like a pants over vest, and then back through the retinaculum with the 3rd pass. And I do that with the foot and dorsiflexion site eversion. And so that's the open repair. So over the last few years, we've evolved now for an arthroscopic Brostrom, which is basically followed in line with the surgeries we do in the shoulder and the knee, which have gone more to an inside and arthroscopic technique. So the indications are really pretty much the same. I would say the contraindications are few, but they're listed here. The learning curve has been noted to be approximately 6 to 10 cases, but it depends how comfortable you are with the scope. Heavy patients, I think in revision cases, probably not indicated. And if patients have a large perineal tear that you know of, you won't be able to treat that through the scope. So if you're doing the arthroscopic Brostrom, again, there'll be supine. I think it's good to mark out this safe zone that you can see here. So you mark out the distal tip of the fibula. You mark out a spot approximately 1.5 centimeters distal, and this is your safe zone. So the anterior border is the superficial perineal nerve. The posterior border is the perineals. And then distal to that, where that distal dot is at 1.5 centimeters, that's going to be where your sutures will be exiting. So that's kind of the safe zone to have that happen. So you do your regular arthroscopy, anterior anterolateral portals, and then you really want to debride the lateral gutter extensively, any synovitis, any impinging tissue, because you really want to be able to see that distal fibula for your anchor placement. You can use fluoro assistance, especially in the beginning when you're learning this technique, to make sure you're lined up. But basically, your anchor placement, you want the one anchor to be just 1 centimeter above the distal fibular tip. So that's the inferior anchor that you see there. And then the second one will be 1 centimeter above that one, and then basically you can see on the X-ray to confirm that. You place the anchors and you bring the sutures out the anterolateral portal. I think it's easy to do one at a time here. And then once they're outside of the portal, the suture outside, then you can bring them back through an inside-out technique, which you can see on the top and bottom there. So you can use a lasso and put it in through the portal, and then you can bring a loop suture back and then pull the sutures out through the skin. And so you have basically 4 sutures that are coming out from the skin there, and then you bring them back subcutaneously. You pull anteriorly to make sure the nerve is out of the way, and then you tie them with the foot and dorsiflexion eversion with a posterior drawer. So across the literature, there's really not any difference noted in clinical and radiographic outcomes when you compare the open versus the arthroscopic. So they're equal strength, stiffness to repair versus open. Maybe the arthroscopic, as some studies have shown, a little bit less pain, a little bit less swelling. Some of the disadvantages, again, of the arthroscopic technique is that you cannot inspect the perineal tendons. There have been multiple studies that have shown a higher complication rate, anywhere from 8 to 15%, typically delayed wound healing, potential sural nerve. And also the open surgery time has been shown to be shorter than that of the arthroscopic and also lower cost. But sometimes Brostrom is not always enough. And so there have been multiple studies now we've seen over the last few years that we think we're doing a good job. In reality, when you look at longer term outcomes, maybe we're not doing as well as we thought we were. So when you look at the Brostrom repair initially, it's significantly weaker than what our native ATFL was. When you look at some of the longer term outcomes in terms of going back to your pre-injury levels of activity, we're not doing as well as we thought we were. Certainly some of these patients that I talked about before, these are higher risk patients, and so you should be thinking when you're bringing them to surgery, maybe you need to do something a little bit more to make sure that long term they last a little longer. And so that's where it came into play that maybe we need to augment our Brostroms a little bit better so that they have better long-term function. So some options, you could of course put in more anchors, you could use Graft, to augment it, and you could use some type of non-absorbable additional fixation, like the internal brace. So the first studies came out in the early part of this decade. Again, they evaluated the Brostrom reconstruction, repair was really about just 50% of the strength of the native ATFL. And then when you added the suture tape augmentation, then it could equal the strength of the native ATFL. So it was theoretically safer. You could rehab these patients quicker. They had a higher load of failure, stiffness, and over time, it wouldn't elongate, so your results would be better. So some of the indications here and the technique, it's basically a flat knotless technique. We'll see this in the lab. It's a relatively easy procedure. It doesn't really increase in time. It's maybe another extra 3-4 minutes. There's no donor site morbidity. Immediately, the ankle is stable. If anything, you have to be careful you don't over-tighten. There's less immobilization afterwards, so theoretically, you can rehab these patients quicker. Over long term, it doesn't elongate as much, so you have better, potentially long-term function, although right now there's still no long-term studies. So certainly there's an increased cost because you have the increased anchors, and you do need a sufficient native tissue repair. So this is not a substitute for your Brostrom, so you have to make sure you have an adequate Brostrom, whether it's with a native tissue or some type of graft reconstruction. And this is, I think of this as more like a seat belt that you kind of lay over the repair to give it additional strength. So the approach is the same through the open approach, the lateral approach. I extend it slightly distal and proximal just to avoid any tension on the skin. Again, you have your bump. When you're first doing this, you can use fluoroscopy. They have a cannulated system now, so you can use fluoroscopy to see where your anchors are, especially in the talus. And the talus side is just distal and inferior to the taloarticular surface, so right over the shoulder. And you want to aim 45 degrees lateral to medial to make sure that you're in the body. You want to make sure you also aim slightly cephalad so you can avoid the subtalar joint. You do your Brostrom repair, and you can see there that on the top part of that picture, the white sutures, that's the sutures from the internal brace, which are anchored in the talus first. And then you're going to lay it over your repair. I do an extracapsular repair, so I insert it into the fibula once it's done between my two anchors that are on the fibula. I place that freer elevator, which you can see there. I place it under the internal brace so that I don't over-constrain it. So you want to make sure you don't over-constrain it because then you're going to stress shield your repair, and then you're going to interfere with the natural maturation of the ligaments for the repair. So some literature, again, Coetzee looked at this and he found improved strength. They can tolerate more aggressive rehab. They can do inversion, eversion, maybe a little bit earlier, and a little bit quicker return to activities. Some other ways to augment it would be an allograft. So allograft reconstruction, in my hands, I tend to do this with revisions. I use a semitendinosus allograft, and then I place an interference screw in the lateral talus. I do the 2 sockets in the fibula, which you see here going anterior to posterior. I put another screw in the anterior fibula, and then I put it down to mimic the CFL into the calcaneus. So when to do this? So in my hands, I do this in a revision. You can also use this if your native tissue is really not good enough to function as a lateral pair. You can also do this if you have perineal tendon instability, and so instead of coming under the perineals, you can go over the perineals and dock in the calcaneus, and that can keep them reduced. Also, sometimes it's a good mode of treatment for patients with a cavus foot malalignment, can give them more secure fixation. So post-op, the recovery is, I usually splint these patients for 2 weeks, full weight bearing, then in the boot for another 4 weeks. So it's 6 weeks, they're basically in regular shoes and a brace, and then start working aggressive physical therapy, usually back to full activities within 3 to 4 months. So in conclusion, the lateral ligament injuries are very common, especially in the young active population. Most of these can be treated non-operatively, but you do have that segment of the population that will develop chronic pain, recurrent instability, and you want to make sure that you address this to avoid long-term complications. When I do my procedure, I'm doing an arthroscopy beforehand to address any intra-articular pathology. I do a minimally invasive reconstruction. It's a safe, effective technique. The failure rate is a little bit higher than we would like, and so I think some of these augmentation procedures are very helpful to provide a strong repair. Also lets us move them a little bit quicker. Maybe that gets them back to sports a little bit quicker, but most importantly, their long-term results, hopefully it will minimize elongation, especially in these younger patients, high-demand athletes, and get them back to sports earlier. Thank you.